Well, thank you very much, Diego. And I guess first and foremost, happy Halloween, everybody. If you can't tell, Matt and I love this holiday.
Yeah, how come the rest of you aren't
Yeah,
dressed
we
up?
expected somebody had masks.
I thought
or
full
something.
costumes were coming.
But yes, thank you very much again for having us. We really appreciate the opportunity to come and meet with the community and especially the provider community because we don't get that opportunity all that often. So again, just for anybody who doesn't know, my name is Andrew Schulke. I am Chief of the Medicaid Fraud Control Unit. I'm coming up on my 19th year with the unit. With me today.
My name is Matt Ross. I'm the Deputy Chief Investigator, and I have been with the unit for coming up on 14 years now.
Okay. So essentially what we're going to do today is we do want to cover one aspect that we were not able to get to on our last presentation, which is essentially kind of protecting your NPI number. And then we're going to dive into some very specific fraud schemes that we've been seeing out there, as well as some abuse neglect issues that we've been seeing out there, and provide, again, some aspects of what we're seeing and what we could maybe do to hopefully prevent these type of things going forward. So without further ado, and yes, there will be very much a Halloween theme throughout this presentation. So yeah, when we talk about policing your number, what we're really talking about, it can be actually twofold. And obviously for purposes of this group, it's probably more so protecting your NPI number, your National Provider Identification number. So just as a really quick aside, so obviously the NPI number, as we know, is that unique 10-digit code, or number that is assigned to you by CMS, the Center for Medicaid and Medicare Services. And essentially this whole NPI process got started based out of the HIPAA Act, which essentially the government was like, look, we have to have a better way to track these providers across both Medicaid and Medicare. So it's kind of the one universal number that's used across both Medicaid and Medicare and other federal government programs as well. So, but the problem is, as much as obviously, you go through the enrollment process and you would think that this is a unique number that would be protected and obviously very secure, because obviously what we're going to get to, how this number can be used. The unfortunate part about that is that it is not protected or secure at all, because these NPI numbers are very much found very easily on just a random Google search. You can do things like MPILookup.com, you can just put in a name and you can get somebody's NPI number very easily, which is incredibly dangerous as we get into the next step. Because essentially that NPI number, and again, really quick, the other aspect of how we use this information is the Medicaid recipient number, which obviously is that unique number that Medicaid is assigning those recipients so they can track the services on the recipient side. But when you look at the law regarding personal identifying information, and again, we won't read the big, long beginning part about it, but essentially what this law is saying, that is, if any type of personal identifying information is used for the purposes of committing a crime, then obviously there's this criminal aspect of using that PII information for the commission of that crime. And specifically in our NRS 205-4617, the specific statute in play here, is the Medicaid account number. And obviously that is a pretty general term, and we have interpreted that, and when we bring our criminal charges on this identity theft issue, to mean both that MPI, the Medicaid provider number, as well as the Medicaid recipient number. So unfortunately, in our cases, we have issues with providers that use those numbers for fraudulent purposes on both ends. So essentially they can use, obviously, that Medicaid recipient number to bill for services that they're not actually providing to those Medicaid recipients. And in that same vein, though, some of these providers can use that MPI number for the provider to essentially list them as a rendering service provider, to essentially obviously submit a claim and get payment. And obviously if that provider has no idea that they provided that service, who that company is, and those type of issues, then that is obviously fraud. So, but it is a number that is used for tracking and purposes. But again, the problem is that these MPIs, the bad guys and the fraudsters know they need these MPIs to commit their fraud. So sometimes, again, they're just out there hounding the internet to find them, linking things to your business fraudulently, and then they're off to the races billing for services that are not being provided.
Before we continue, how many of you have sat through one of our presentations about our unit?
Oh, yeah.
Okay, how many of you are unfamiliar with who the Medicaid Fraud Control Unit is? Okay, let us back up a little bit before we get into the specifics. So the Medicaid Fraud Control Unit, our whole point on this earth is threefold. First, it is provider fraud, Medicaid provider fraud. So the doctors, the hospitals, psychiatrists, essentially the people billing Nevada Medicaid for services, when they are lying about those services that they provide, it's our job to step in, investigate, and prosecute them. We do that criminally, that's my job, and we also have a civil side that does it non-criminally. So there's penalties, fines, restitution, things like that on the civil side they're required to pay. When it rises to a criminal level, we make a criminal case out of it. That's our first and foremost thing. The second thing is to police the Medicaid system. And when we say that, what I mean is if there is someone within Nevada Medicaid or one of its contractors who is acting inappropriately, maybe they're in cahoots with a bad fraudulent provider and they are facilitating their enrollment or doing something like that for a kickback, a bribe, whatever you want to call it, we would also step in and investigate and prosecute those cases. And then our last mission, our last purpose is abuse and neglect of the elderly and vulnerable, primarily in healthcare facilities, but also in private homes if there is a Medicaid funding nexus. So for example, if there's a home health provider going into a private residence and instead of providing home health services, they're beating up grandma, we could then bring an abuse neglect case against them. So that's our mission. Generally, the Medicaid Fraud Control Units throughout the state or throughout the country, every state has one. Some of the territories have them as well. Basically, anywhere where Medicaid is allowed, there's a Medicaid Fraud Control Unit. They're generally housed within the Attorney General's office, and so we are like that, housed within the Attorney General's office. Andrew's a criminal prosecutor. I mean, he's our director now, so he doesn't do a lot of cases anymore.
Thanks, man.
Sorry, not that you weren't bad at it. I mean, you were great. That's why you're in charge. But that's what we do. And so today, like Andrew's talking about, we're going to talk about some of the trends that we're seeing, both on the fraud side, but also on the abuse and neglect side. And to be honest, the number of referrals that we've received for abuse and neglect has skyrocketed in probably the past year and a half, 2 years. And a lot of it has to do with patient dumping and unlicensed facilities and things like that. So we'll talk about that. Are there any questions about who we are and what we do before we jump into the actual specifics of what we came to talk about today? Good? Everyone understands who we are? All right, keep going.
And I do think we should highlight in the abuse neglect realm, we're commonly named in our federal key TAMs that are filed federally, and we're named as a state, and when there's allegedly abuse neglect, which sometimes has a fraud nexus too, happening in skilled nursing facilities. We've been doing that since we became a unit in 1991. But really, since Matt and I really took over the unit about 6 years ago, our main emphasis has really been building up our abuse neglect cases just locally. And that's why, obviously, historically, those type of cases have always gone through local law enforcement, get prosecuted by the district attorney's office. Obviously, in the civil side, more of them are just handled by HCQC, Healthcare Quality and Compliance, the licensing agency. But essentially, again, we've been around so long that we see where there's some holes and we see where there's some problems. And that's why we're trying to step in and make some inroads that, again, the locals are not really set up to do those type of things. They're looking at the individual who slapped grandma and the heinous abuse and those type of things. And our focus in our cases is mainly on the neglect side. Those are harder cases to prove. And especially in Nevada, as we talked last time, you do not need to show actual neglect to make a good neglect case. Really, in Nevada, our statutes say you only have to show that elderly person, was placed in a situation they could be harmed to make a successful criminal neglect case. So anyway, we're making more inroads in that, and as Matt said, we've definitely seen a rise in those referrals and cases we've received. And we're also working with our partners with Medicaid and the managed care organizations to let them know about how some of these abuse neglect issues can really parlay themselves into fraud arguments. And heads up, we'll be talking about that next week at our presentation. So anyway,
I have a couple of questions.
Please.
A couple of scenarios. What if someone is fraudulently billing Medicare, Medicaid? Is there somebody that we can contact, like within your office?
100%.
Absolutely, yeah.
We're going to talk about it.
Okay.
We're gonna have all our
Because I
contact.
was at the last meeting that you
Okay.
guys had here. And then the second instance is, what if a patient, there was a wrongful death, are the families allowed to reach out to you guys?
100%.
100%.
We take referrals from anyone and everyone.
Yeah.
Okay.
And I should mention, we are entirely referral based. We're required to be. We can't proactively go into the data mine, look for outliers or things that stick out. We have to have a referral that comes in, or while investigating something, if I see something, then we can open a case on it.
Yeah.
But 99.9% of the stuff we do is because someone reached out and told us something was going on. So if people don't call, it's not going to get looked at by us.
And the only thing just to highlight, when we do have these issues, especially like a wrongful death or something that's happened in a skilled nursing facility and the family gets involved, and a lot of times that family is looking to bring some type of civil action themselves on behalf of the family. A lot of times they'll go out and they'll get an attorney that will handle that aspect, and a lot of times that's who we get the contact from, is that attorney asking us if we've received this referral and if we're looking at this case as well. And it gets a little bit, I won't call it awkward, but it's unfortunate, just like we can't represent like the family. Like our job is just to investigate the allegations and the issues that we're seeing and to establish if there was a crime or if obviously we can make a civil component out of it. Unfortunately, I think a lot of times the family, and obviously I think it's really their attorneys, are thinking we're in this together and we're fighting this together, and we just can't have it like that because we're, by law, we're the Attorney General's office. We cannot represent individuals in that respect. So we just got to
go to the Department of Justice first and then Attorney General?
No.
Or Attorney?
It could come to us. I mean, some things obviously can go through the feds and then we could hear about it, but it doesn't have to. It can come directly to us and then we can start looking at it. Now, obviously, if it's going to be something like if we're having a fraud issue and then there's more of a Medicare nexus or basis to it, we'll rope in the feds just because obviously that's their kind of deal. But to a certain degree, we can also handle Medicare issues at the state level with proper authorizations and approvals, and we've done that. And so to a certain degree, and we're seeing that also as a trend. Our local U.S. Attorney's Office, they're busy, they have a lot going on, and the federal OIG has said, look, we want to take our Medicare cases through you guys at the state level. And we've got a couple cases right now where we have to charge it under a theft type of scenario because it's not Medicaid fraud, it's obviously Medicare, but they have authorized us to essentially bring Medicare to the state level. And we've got 2 cases right now criminally that we're working right now.
And on the families calling us, we can't be on the family's team per se or their attorney's team, but let's say we're successful in bringing a civil action or a criminal case against a provider for a wrongful death situation.
Right.
How much stronger does that then make that attorney's case?
Exactly. Especially
Defend or helping that family.
And then what about like a
Sorry,
pre-dam?
perhaps we can get your presentation before the questions.
Oh, sure. We can dive in.
Sure. And we'll have time after if
Yeah,
you want to
we'll
stick
stick around.
and
We'll be
talk.
around.
You want me to keep going?
Sure.
Okay.
Oh yeah, this is your.
All right, so Andrew's explained how your NPI is super important. You need to protect it. We have a number of cases where individual rendering providers, say a therapist, their information's been essentially been taken and is being used improperly by a company or by multiple companies. We also have cases where companies, like the billing provider's NPI, is being used improperly. Either they have farmed it out themselves for money, or someone got a hold of it and is now submitting billing under them. We have a number of cases where someone within that organization, an authorized user per se, went into the Medicaid system, changed the bank account information, started submitting fraudulent billing, and that bank account goes to them now as opposed to the actual owner of the company. We've had a number of cases like that. So on both sides of it, protecting that NPI, both as a rendering provider and as the billing provider, is very, very important. It's important to know the people that are working with you, vet them. Don't just hire anyone and have them handle all your Medicaid stuff because documentation is difficult and the bureaucracy of Medicaid is a nightmare. You need to know who you're working with. But up here I have an example. So a rendering provider, when they are linked to a company in Medicaid, the company has to submit an associated providers list. And I apologize that this isn't super large. But for here, we have a group provider named Haunted House Behavioral Health, and they are linking Andrew Schulke to their company. Now, Andrew never saw this. I basically typed his information in.
That's not my signature either.
Put an email address on here that will go to me. Put my phone number here, so if Medicaid calls to verify whether he's being linked to my company, Haunted House Behavioral Health, it's going to come directly to me, and I'm just going to pretend to be Andrew. And then I forged his signature in about 2 seconds in Adobe PDF. And Medicaid is going to look at this and be like, oh, that's great. Yep, that's perfect.
We got a signature.
Linked.
Done.
And then I'm going to start billing however much money I want under Andrew's name. And generally what happens is I'll start billing an exorbitant amount. Maybe I'll start small. Maybe I won't be because I'm going to just take the state for $2 million and then I'm going to leave to some foreign country that I can't get extradited from.
Non-extradited.
That's my plan. So I link him and then I start billing, let's say, 75 hours of service a day under Andrew's name. And we're talking, when I say 75 hours, we're talking about a time-specific code where he has to spend that entire amount of time with the client. So he can't do 75 hours of, say, face-to-face psychotherapy every single day, right? There's only 24 hours a day. Medicaid will see that probably like a year from the time I submit that claim because they're slow to notice things. They'll red flag it. They'll start investigating. They'll request records. They'll reach out to Andrew, maybe through this number. Probably not, though. Maybe they'll go to his actual enrollment application and reach out to him and be like, what's going on? Because they think Andrew's the bad guy. Happens all the time where they think the rendering provider is the one lying about the services. Even though my company's billing, they're going to think Andrew's part of it. And they're going to start looking at him.
And we should say when Medicaid reaches out, they're not picking up the phone and making a call. They're most likely going to send either a verification of service letter, VOS letter, or just a straight up recruitment letter saying you owe us all this money because we know you didn't do these services. So they don't usually check like, hey, we just want to check in. It's usually like, give us these records because we think you did fraud, or give us this money because we already know you did fraud. So just that's how they, on the fee for service side, how they approach providers.
So now Andrew as a provider is like, what is going on? I don't even know who Haunted House Behavioral Health is. I've got this letter from Medicaid saying I've provided all of these different services for their clients and I don't even know who this company is. He sends it back to Medicaid. Medicaid's like, oh, we have a problem, send it over to the Medicaid Fraud Control Unit. They send it to us. I go to Andrew's house or his office and we're knocking on his door and now he has the police in his face asking about potential fraud. And Andrew might seem cool and calm and collected on the outside, but he's peeing his pants because he's worried that his career is over.
Number 2.
Okay. He's scared to death because he thinks his license is in jeopardy and it's not his fault whatsoever. He has no idea this is happening. Now, this has happened to us so many times. We're used to it. When we show up to the provider, we'll calm him down. Hey, happens all the time. You're not alone in this, whatever we have to say to calm him down to get the information that we need. But a lot of times, they're so scared they want an attorney before they talk to us, so now they're paying an attorney to represent them, all because some bad guys got a hold of their NPI. He's going through all sorts of fear, worry, and now he's having to financially pay an attorney to help represent him when I come talk to him. Generally, that's how it goes. And I'm not even going after him, but he's so afraid he's willing to pay the thousands of dollars to an attorney to represent him.
But now, an unfortunate from our perspective too is now we have to work with this now potential witness to get them cleared, because obviously from our perspective, you're on the claim doing this service that we show you wasn't done. So we have to start the fraud at that servicing provider level, and then see if obviously working with that provider, if we can show you really didn't know this was happening, you were taken advantage of, and then essentially turn that person into a witness to use against that company. And again, the other unfortunate part of what we're seeing, and a lot of this is in the arena of behavioral mental health, because that is, again, the majority of the referrals that we get, is you might have an individual provider that goes and meets with a business and interviews and gets hired, and they think that they're working for this one business. Well, what they don't know, and that business might look legitimate and might look, everything is on the up and up, but what they don't know, that provider, is that business is actually being puppeteered by a husband and wife couple or somebody that's obviously in the business of fraud. And that obviously husband and wife couple or the person doing the fraud is also affiliated with 10, 20, 30, 40 other mental health businesses. And obviously what the individual provider doesn't know, once they get hired and again are thinking they're working for that one business, their NPI number has now been shared and shuttled amongst those other 20 businesses. And now this type of thing is happening with those other 20 businesses to link them, to bill them, and they might think again they're working for that one company, and then Matt shows up with all the claims. No, you're working for 20 different companies. And that's because again, they got them in the door, they got that information, and then they went off to the races because they had it and they had what they needed to do the fraud.
I'd say every couple of weeks we interview a provider, generally a licensed individual, therapist, doctor, whatever it is. We bring all the claims data, every company that they're linked to, and they're like, I don't know 75% of the companies on this list. And I'm like, well, I mean, last week we did one and they billed $10 million under your name.
Yep.
In 2 years' time, they billed $10 million under your name and you don't know 75% of them. And the ones you do know, you hired on as a supervisor, a clinical supervisor, not providing direct services to clients. You're just supposed to be reviewing the documentation, making sure that their actual rendering providers have the necessary qualifications, but they just started shoveling claims into Medicaid system under your name. It is an easy system to defraud. Yes, go ahead.
Are you guys getting these from Medicaid itself? Because I'm the CMO for MCO. I've never turned one of these type things into you. Am I just missing all these?
What MCO you work for?
Well, I mean, Silver Summit, but I turn in fraud, waste, and abuse stuff all the time, but not where a provider says that he's not even part of that company?
So we do not see it as much with the MCOs because, we were actually talking about this morning, because Medicaid fee-for-service follows what they call the pay-and-chase model. They are not looking at these claims as they are coming in. And that's why we get, as Matt's talking, these like crazy 70 plus hours in a day type services. In our experience working with you guys in the MCOs, you don't have that problem because you have this magical thing called prepayment review.
Well,
I mean, it's not
it has.
perfect.
I have like 2 or 3 cases right now where there's MCO claims involved in addition to the
For most part,
fee-for-service.
We don't do prepayment review unless we suspect it, but we have this SIU unit that is
Well,
like
we know.
you guys.
We got to meet
Yep.
with them next week.
Yep. But I think you guys just have things in place that the true fraudsters know that's going to make it more difficult for me. If I just go fee for service, I can just get the money, no questions asked. So I think the true fraudsters are just more focusing on what's easy for them and not having to jump through the hoops necessarily to still do the fraud, but just not work as hard for it.
Also, it's been our experience that the MCOs generally have better edits in their claim system.
Yes, I think you're denying.
And so
more.
you're denying a lot of the stuff where Medicaid is just
paying
it all out.
Correct.
So you guys do a much better job of catching the fraud, but it still happens. Like I said, 3 right now where there's MCO claims involved and there's doctors that are like, I don't know who these companies are that they're billing you guys. So it happens, but it's just not as often as fee for service.
Correct.
So one thing I want to note is once this is done, let's say my application gets approved, and then let's say I get shut down because Medicaid Fraud Control Unit comes after me, or SIR just says we don't want to enroll with you, you're billing too much, you're done, and I get shut down. I will probably know multiple other bad fraudulent providers, and I will take this exact form, white this out, white out the MPI information, put whatever company I'm giving it to on, and then they will use Andrew's name again. And then they'll get caught and shut down. And then they'll send that, and they might sell it, they might give it, whatever they do, to another bad provider. And so I have seen the exact same doctors used over and over and over again, because this right here, once it gets approved one time, they know, okay, Medicaid's not even checking this, they're just signing off on it, they're approving everything. They just farm that out to every bad provider they know. Mm-hmm. And that's why when I started 14 years ago, 90% of my cases have been behavioral health, and my first case was behavioral health. From that initial case, I've probably had 30 plus convictions of individuals who worked at that company because they realized, oh, we can do this ourselves. Let's start a company. 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 And then they just kept doing and got better, honestly, at doing it. We are at a point now where Medicaid fraud used to be like an individual one-off thing. We've got a bad therapist here, we've got a bad PCA here, one-off kind of stuff. Now there are organized fraud rings, actual criminal rings, who are planning this, who are selling this dream of this luxury lifestyle. You can make $300,000 every 2 weeks. No problem. Great, because right now I'm working at McDonald's making minimum wage. And so I'm going to go and you're going to teach me how to do this, and they'll teach you how to do it, and then you essentially become a co-conspirator in this fraud scheme.
And I think the other thing we've definitely seen over the years, and again, there's the rampant explosion in the fraud in the arena of behavioral mental health, is we are having some very unscrupulous people coming into our state really puppeteering and manipulating these behavioral health companies. These are people that have extensive criminal histories. They've already been convicted of Medicaid fraud, so obviously they're excluded. Essentially, they can't get in legitimately, but they know the money's still there, and they know how easy it is to get, and they know, again, as Matt said, they can sell this dream. And look, I've convicted 4 pastors in my lifetime. The church is an amazing place to recruit people to sell the dream, and it's unfortunate because you're preying on that aspect of the vulnerability of some people, and you sell that dream. And again, commonly when we go out and talk to the providers, and we give the, basically we say, look, if you're told something that's too good to be true, it is. Get out of there, do not go involved, because all they're wanting is this. That's all they want, the fraudsters. Once they get that info, they're off to the races. And so it's becoming increasingly more prevalent. And again, from what we're seeing, it's becoming worse because we have all these very bad actors coming in here that, again, have these kind of organized crime type ties that are manipulating fraud through these straw owners. And again, we have our biggest case charged right now. It's a RICO racketeering style organized crime case, because that is exactly what we believe. This husband and wife couple was puppeteering up to 200 behavioral health companies in our state and making millions of dollars doing so. So it's gotten pretty crazy.
but we won't know about it unless people call
Yes.
and report it.
Message.
And honestly, with the big rings, we generally won't know about it for some time until we start seeing, wait, this is the same doctor, these are the same kind of procedure codes, same addresses a lot of times, and we start putting all these puzzle pieces together and realize, oh, we've got something bigger here. And we're going to talk about another one. One other trend that I'm seeing is, how many of you are familiar with the various types of providers within Nevada Medicaid? So mental health, type 82s, type 14s generally, right? They're moving away from that, the fraudulent ones, and they are enrolling as type 20s, so physicians, or type 24s, nurse practitioners. Because we have worked so hard with Nevada Medicaid to clamp down on mental health fraud in this state. There are so many regulations. When you look at the enrollment application for a type 14 or 82, there's all these attachments with it. Signing, having their clinical supervisor, their med, all these different people have to sign off and initial all these different policies indicating that they know what's going on. There's some notarized signatures that they have to do, all for type 14 and 82 because the fraud there's been so bad. Type 20, type 24, none of that. It's just the basic enrollment application. And they realize that. And they realize that enrolling under those codes allows them to bill a whole bunch of different things. And so all they do then is they'll contract with the doctor, an actual MD generally, or a nurse practitioner, and say, hey, I'll give you $1,000 a month to be my supervisor. And that supervisor doesn't realize that hundreds of thousands of dollars a month are now being billed under their name. And they probably have their own clinic or some place that they actually work full time, and have no idea that they're getting all this other stuff is being built in addition to what they're actually doing at their own practices. So it is definitely something to consider, something to worry about. If you take anything from our presentations ever, don't be naive in the sense that the healthcare system is safe.
Yeah.
It is not.
Medicaid is not looking out for your best interests. They're not.
Medicaid's not, and there are legitimate predators out there trying to take advantage of good providers and utilize that. They have to have that NPI, and I'll get to you. They have to have that NPI. Bad guys need that. You have to have it as part of HIPAA to submit the billing. Without it, they can't do it. So that is a key component in every one of their fraud schemes. They got to have it. Go ahead.
I'm sorry to go out of order.
No, no.
You raised a great point about these physicians who have their own practices and are doing something like this, and things are being done where they sign this contract saying, I am providing non-clinical services and doing chart review, and these claims are being submitted under their NPI.
Yep.
Is there a tool or some way that seems that they can self-query like the National Practitioner Database?
Great question.
What revenue is being attributed to their NPI?
If that's our next slide, that's going to be yes.
Boom, it is. You can't see it,
how
but
it worked
yes.
out. Ah.
Yes. So back in the day, before
pay you later for
Medicaid
asking us
went to
later.
their whole MMIS portal, went to the actual portal that they're using now, back in the day, you'd have to call and work your way through Medicaid's bureaucratic phone lines to finally get someone to say, who is my NPI linked to? What billing providers are billing under my name? And it took forever, and it was a nightmare. Now you can log on into the system under your own account and see what providers am I linked to. And so that's our recommendation. I literally checked this 2 months ago with Medicaid. I said, I need you to explain the system to me so that we can tell good providers what they need to do to check on their stuff. And so you just log in, just like you normally would. The website's up here. You can't see it back there. I can
We'll
barely
send
see
it to you,
here.
Diego, if you want to distribute it. Oh, okay,
Yeah.
then perfect. Then it'll be part of it.
But that's the easiest way to do it. I'd love to say you could reach out to the National Provider Database, but they're not going to know.
No.
It's going to be within the Medicaid system that's going to be able to tell.
But you did bring up a good point of one thing to curb this type of issue, which again, we do not see. These physicians actually have contracts with the companies specifically delineating what their role is and what their job duties are. We have so many cases where we're going to these physicians and they're like, I just signed up as clinical supervisor. Okay, well, where is that memorialized? Where's that understanding? Oh, I don't have a written contract. I have nothing in writing. Well, then, yeah, you need to protect yourself in that regard. So honestly, having that kind of contract or something in writing that delineates what the scope of the practice is and what that physician's role is going to be fantastic, especially if it's something when Matt comes along with claims and asks, why is all these claims being billed under your number? Then you bust out the contract. This is all I was doing for them. I have no idea either. You're instantly in witness territory, and now we're going after the bad guy.
Yeah, having that contract is super important. I'd also caution, especially for you that are working for MCOs or insurance companies, be mindful of those doctors or those providers that you do see associated with 10, I don't want to put a number on it, but many, many companies. Because yeah, maybe they're being taken advantage of, but we have run across doctors and therapists and things like that who are in on it and who are totally fine farming out their NPI to whoever wants it. And they're literally give them a signature stamp and say, here you go. I'll take my $1,000 a month. And they are raking in the money. So it's just something to be mindful of. You obviously don't want to associate with those kinds of providers. So maybe ask some questions, dig a little deeper, figure out what's going on. Yes.
My understanding, and the esteemed Dr. Evans would know better than me, but isn't there a new bid coming up to move a lot of the Medicaid fee-for-service to the managed care companies?
Correct.
That seems like that could assist you guys.
I think it will tamp down on some of the fraud. Now, here's my experience. We're never going to stop all of it because they always find a way around it. Whatever we put in front of them, they find a way around it. The easiest way for me to explain it is I live in a neighborhood, just like most people do, right? I shut my garage because I don't want anyone walking into my garage or my house to steal stuff. My neighbor doesn't. And I'm not going to tell him not to leave his garage open because when the bad guys drive down my street, whose house are they going to target? Right? They're going to target his because he's left it wide open to them. And so right now, Medicaid is that wide open garage in comparison to the MCOs.
Yep.
So it's going to get better, but they will still, if they want it, they will find a way around it.
Yeah.
And I don't want to say that we don't have any MCO fraud cases, because we do. We 100% do. But they have SIUs, each one of them does, that investigate stuff, and when they think it rises to a criminal level, they send it over to us. And it's great. It's a great system. But you are correct. Right now, we're about like 70 to 75% MCO coverage in the state. We're moving that to 90 plus, I believe, percent.
2026, yeah. And it'll at least cause more of those funds to go to entities that are more mindful and looking at a lot of what's going on, where just the fee-for-service side and, again, how big it is and their lack of resources, just a lot goes in and out without any questions asked. So I agree. We're hoping that we see less. To a certain degree, we want to see some fraud. Matt and I have 12 years left to retirement. But we do hope to see less of this egregiousness, just because some of it is just like, you cannot believe that this fraud went on for as long as it
The
did.
biggest part of this is that with Medicaid and Medicare too, there's almost no prior authorization. Everyone hates prior authorization. But prior authorization is our biggest tool against preventing fraud.
It's closing your garage door.
Yep.
That is what a prior auth is.
With Medicaid, there's like no prior authorization, but we have, we've tried and keep it low for the doctors, but it prevents fraud.
And
100%.
No, 100%. And just this is classic because we've seen this on the fee-for-service side for so long. I believe it was 2015, 16 when behavioral health was really at still taking off. But when basic skills training, psychosocial rehab, when those were really the hot issues, Medicaid decided we want to do prior authorizations for these just because there's so many of them. But obviously, whenever Medicaid does those kinds of changes, they have to do it through an open public workshop because they got to announce we're making these changes. So they announced this workshop, and literally we were at the Grant Sawyer building still too. Like, this was crazy. They were literally picketing like outside saying, you're taking away our services. And then they went in front of the legislature or Medicaid too and saying, you're going to cause all these people to suffer and blah, blah, blah. And commonly, this is just, again, from what we see with Medicaid, when it gets prickly and things get, providers start complaining, they back down. And so unfortunately, they tried to do that, and then as part of that, I got labeled as an instigator and a problem child.
It was pretty funny for us, not so much for him. They put a website out called Medicaid or Medicant.org.
Right.
Andrew got a bunch of death threats on it. They called him Andrew Schulke, which I found hilarious.
That was great.
But literally, we could stand inside the building, and they couldn't see us through the windows, and we could point out, we have a case on that person, we have a case on that person, we convicted that one, just like that.
And some of these people would be up there testifying and say, oh, you're going to affect my company. I was like, I know you're out there doing fraud. You're not affected. You're making millions of dollars.
Healthcare fraud is very, what's the word I'm looking for? Prevalent everywhere. There are a number of people on your ballots at this time that we have convicted.
Yep.
That are running for public office. Right now, as we speak, we convicted them.
Yep.
That's such a shock.
I think that's part of getting into politics.
I mean, it is funny when I'm going down the ballot, I'm like, I know that name.
Yeah,
How do I know that name?
Yeah. Oops.
So, I mean, it seems like you just explained in like 7 minutes how we can all go out and do this. It seems like a simple text message to a provider saying, hey, someone comes and says, I'll pay you $1,000 a month, and then I get a text message that says $1.4 million was billed last month.
Yeah.
Hold on, what are they doing with this, right? At the very least, you cause them to say, I'm not getting that.
Exactly.
Right? So is there not more...
I would love if Medicaid, every time a provider was linked to a group, a company, if Medicaid would do that. Just reach out, not based on what number the company is giving you or the contact information the company is giving you for that provider, but go to that provider's actual enrollment application for themselves individually. Use that information to reach out to them.
And that is, you're absolutely right, because one of our biggest frustration is we provide this information, or the providers go and find this, and they find all these fraudulent claims, and then they don't do this last one, most important part. You got to report it. You got to call us. Like, there's nothing we can do if then you find that. And we understand the stigma about ratting out your other medical professionals. You don't want to be blacklisted, if we can say that anymore. But it's like, if we're not going to, combat fraud and get it out of our state, unless you're reporting it, how are we going to do that? And I think that's the other thing that we commonly see if providers are identifying these issues. They're either trying to handle it in-house or maybe work something out with Medicaid, but obviously getting it to us, especially if it's very egregious, we can take them criminally, we will get them out of this state, or at least make it harder for them. So, I mean, honestly, that's part of it, is just making sure we're aware.
The other thing, and it would cost Medicaid next to nothing, no manpower, no time, barely any money, is change the form so it requires a notarized signature.
Yes.
It is the simplest thing that they can do. And yeah, there'll be notaries that falsify it. Absolutely.
Yep. Make it harder.
But it's another layer, right, to preventing the fraud. And we have given that recommendation to Medicaid 1,000,000 times, and there's constant pushback because they say outside influences, they say provider, we're trying to prevent barriers to become a provider, all these things. And I'm like, it's a notarized signature. It's next to nothing. These people have gone to medical school.
Medicaid currently on the fee-for-service side is literally allowing you to type in your name to get access to millions of dollars. There's no signature required. Now, we heard because we've complained a lot about this, and we've honestly, as Matt mentioned before, like we have told, like we think this is fraud within the system, guys. Like we're trying to tell you to change this, or we're going to take action. And so now we're hearing they might institute some type of picture taking when you sign. They'll snap a photo of you. Are you going to keep that photo? Like, it's got to be stored somewhere. Again, you've got to have some protections before you allow access to millions and millions of dollars. And they do not seem to respect that aspect of how we approach it.
Can you explain, so if a provider has a provider within their agency, they're doing fraudulent activities, if the provider comes to you guys and reports that provider, they're protected?
Yes,
correct.
So we have a rule in the unit. What do you refer to it as?
Self-disclosure.
Self-disclosure, where we will not go after whoever reports it. Like, let's say I was a provider, I realized I've got a bad actor in my company, or maybe we made a mistake. We go to the Medicaid Fraud Control Unit and say, hey, we screwed up, or I've got a bad actor, how do I remedy this? We're not going to go after you criminally because you came forward, self-reported, did the right thing. Yeah, we'll probably need to make Medicaid whole. We'll work out a payment situation, whatever it is, to fix the problem. And then if there is a bad actor, we'll go after them criminally. But we do that because we need people to come forward and report these things. And we want good providers. We get it. There is a need for all healthcare in this state, right? Everything is hurting. We need good providers. And so we don't want to discourage the bad providers from coming and reporting or the good providers from coming and reporting because, as we'll explain soon, fraud within the system makes it so much harder for good providers. And I'm going to share some examples of that from other states where they took drastic action because they were severely taken advantage of. So that's the NPI fraud. All right, so just as a case example, a new fraud ring that we think we're seeing. So far, we've identified 20 different companies. They're all nurse practitioners or physicians. At least the companies are that provider type. They are billing allergy testing and various community health worker claims, like this education type stuff. We're not super familiar with the community health worker stuff, so we're educating ourselves on that. That's a whole new thing for us. We have seen some allergy testing cases in the past, so we're pretty familiar with those.
What we can tell you, though, from what we've learned so far, these community health workers are supposed to be some type of liaison between Medicaid and the recipient to help educate the recipient about this is what you're going to be getting. Like, this is what is going to happen going forward. They're supposed to be kind of a fill in the blanks. The problem is we see these community health workers signing off as actually doing like a therapy or doing like a service, which again, we know based on what we already have for Medicaid, that is not allowed. But again, it's how they're being manipulated.
So within these companies, they're all billing similar rendering providers. So they're the same 8 to 10 PAs, NPs, or MDs. Talk to some of them. We've talked to some of them, and Medicaid has reached out to some of them. Some of them are like, yep, I am associated with every single one of those companies. I've done every one of those services. And then we look at the service and we're like, well, it's not humanly possible for you to have done them. We go get the records from the company, and that doctor is not on any one of the records. So we know some of the doctors are in on it, but then there's other ones who have no idea. Like the one we talked to last week, $10 million in billing under her name, she had no idea. And she's associated with probably 7 of these companies.
And she was one of those that, from my understanding, she went and applied and worked for one company, but then her number got shuttled around.
As a supervisor,
Yep.
Associated Providers list shared with all the other ones. And that's generally what we're seeing.
That's how you get 25.
So it's definitely a new fraud ring, but this is just a great example of how NPIs are being used illegally. And when we see that, yes, we're going to go after them for Medicaid fraud, but like Andrew explained, because of our state statute for identity theft, we can treat your NPIs or the Medicaid recipient ID numbers as personal identifying information. And so when they're using that information unlawfully, we'll also hit them with identity theft charges. All right, patient dumping / improper discharge. So we've had a pretty good uptick in referrals about various hospitals, skilled nursing facilities, other places, discharging people when they shouldn't be discharged and not adhering to CMS's conditions of participation. Anyone familiar with conditions of participation with CMS? So essentially, they're rules that facilities have to follow to be within Medicaid or Medicare. Right? You want to accept Medicaid or Medicare funds, you have to follow these conditions of participation. And there is a whole bunch of them related to discharge and discharge planning. Now I should say, I am not talking about situations where, say, Andrew, who has full capacity, knows all this stuff, goes to the hospital and just wants to be catered to and taken care of and refuses to leave the hospital. Right? You can kick him out to the street and he can fend for himself.
Thanks, man.
Right? Sorry, buddy.
It's all good.
I'm talking about people who cannot take care of themselves, whether they have a physical incapacity or a mental one where they can't take care of themselves. They are vulnerable adults, they are elderly, whatever it is. And this is how I have to explain this. My wife's a nurse. She disagrees with me on a lot of this stuff. She thinks that I should side with the hospitals and facilities more. But I try to explain it to her this way. When our daughters were 3 years old, would it have been okay for a hospital to kick them out on the street? By themselves, fend for themselves? Absolutely not. They can't take care of themselves. And that's the kind of case I'm talking about, where they're kicking people out, discharging them to unsafe facilities or the street who can't take care of themselves.
And the only other, just real quick, is the other thing, aspect of these working is when the public guardian's office is involved.
Yes,
because
big part of it.
obviously, whenever the public guardian's office is involved and it's a ward of the state that's in the hospital, based on the CMS rules and the laws behind it, I mean, that public guardian office needs to be notified prior to discharge to make sure they're aware of what's happening to their ward. And again, obviously, we've got a number of cases where that's not happening, and that person is getting discharged to the street, and the guardian's office has no idea, and now we're getting a referral from the public guardian's office because of that. So we're seeing those type of issues as well.
And then them putting them on L2K holds to justify they have
Yeah.
behavioral problems, and then shoving them off.
Yes, well,
Yep.
I'm going to talk about that. I should specify, so those conditions of participation, CMS has them up online. They're codified in CFR 42, CFR 482, but they very closely mirror our actual state statutes. So if you just went to our state statutes, they're almost identical, word for word. Like someone in Nevada was like, I'm just going to mirror everything we do off of what the feds are doing.
And Matt and I have a whole, it's like 40 slides just on hospital discharge where we go through the CMS, or excuse me, the federal laws, and we go through the state laws, because we want to show that there's, and again, especially when we're talking the law, a lot of times there is not a good overlap, or you got these discrepancies. In this arena, the law is very much in tune between the state and the Fed on these discharge issues. So there's not a lot of wiggle room that we do sometimes see when we have those conflicting laws.
All right, so I'm just going to cover a couple of the actual conditions, the ones that we get the most complaints on. All right, so a hospital must, and I know it's hard to see because it's small. I have it bolded and underlined. When it says must or shall in a law or a regulation,
No question.
you have to do it. There's no option not to, okay? So a hospital must have effective discharge planning process. Every one of them basically does. That focuses on a patient's goals and treatment preferences and includes their caregiver or support person as active partners. We get a ton of complaints and referrals from families who have, say, grandpa who has Alzheimer's, has no capacity to make decisions for himself or take care of himself, or people who are wards of the state have public guardian assigned. And those individuals are being discharged to shelters or to the street, and the family has no idea because they were never told, never contacted, whatever the situation is. Happens all the time. Hospitals can't do that. They are required to include the caregiver. Now, sometimes they might not know, and we'll definitely take that into consideration if they have no idea or no way to tell. But a lot of the ones we get are wards of the state, and they knew they were wards of the state because they've been there 10 times. Or we've even had cases where when they got first admitted to the facility, they reached out to the public guardian and said, hey, we've got your ward here. And then 2 months later when they discharge, they don't tell the public guardian anything, and they say, get out of our hospital. Go.
Or a situation, I was reviewing a referral this morning where it's a hospital where they discharge a patient, and again, it's a referral, so it's all allegations, but the allegation is that the hospital knew the patient was being discharged to the home, the spouse was at home, but that spouse at home was already bedbound. So you're discharging someone to a home that already has a bedbound spouse, and this person needs care as well. Well, and again, what we're missing, there's no corresponding like home health or PCA kind of referral to make sure that that continuation of care is happening. Well, again, if the hospital knows they're discharging someone into that type of environment without having those type of precautions in place, that's neglect, criminal neglect potentially. So that's a problem. Yeah.
We get a number of referrals where families are like, we cannot provide the necessary care for our loved ones.
Yep.
The hospital comes to us and wants to discharge, and we say no. And then they pressure and pressure and pressure and pressure us, as opposed to finding resources in the community for them to go to. They don't do it. They don't care. They are there to make money.
Yeah. Well, but we do need to clarify. I mean, look, Matt and I are not ignorant. We definitely understand hospitals are not hotels. That is not what they're meant for. It's not for an indefinite stay. But I think the problem, and this is, again, we've been having these conversations for 5-6 years now, is finding some happy middle ground or something between the hospitals and the community where we can work something out so we're not having these discharges. Because we understand the hospital perspective, you need the beds for the sick people and to help them and those type of things, but we can't have this also happening where you're discharging people to the street that, oh, by the way, are out there getting hurt and then getting admitted to a different hospital within 24 or 48 hours. So it's finding that happy medium to try and make something that'll work.
Let me ask you this, because there was a system I remember when I would work on discharges, and there was 2 occasions where I told the case manager, all right, we're going to discharge tomorrow, the family's going to get, and she stood up and went into the room and said, I told you you needed to leave tonight, and like yelled. There was another one where the patient had a glioblastoma, and I remember thinking, like, Jesus Christ, I had never seen anyone treated like that. I didn't know who to tell them. I mean, literally yelling at the patient and the family, saying, no, we are done treating you, we are done here, etc. And just, I was like, okay.
And see, those type of examples we don't hear about because obviously a lot of times when we're hearing the discharge, it's, you know, the soup of who you got, the social work, you got the physician, all these people signing off on discharge. But if you have one person out there like making that call or making that threat, and to a certain degree that's kind of maybe exploitation to a certain degree of holding that undue influence, I have the power to kick you out of here, we can maybe make an issue against that one person making those statements. It might even come to verbal elder abuse. I mean, when you're having that kind of attitude, if that person is really, now again, if that person is overstaying their welcome and there's no medical reason for that person to be there, then we're going to have an issue. But if there are legitimate reasons.
I would see in other systems that was very different. When I was like, hey, the patient can, and you'd see the case manager just be like, oh, all right, well, it'll have to be tomorrow. But that one shocked me, and one of them bit him in the ass because, I mean, that patient's relative went insane inside the room.
Yeah.
But,
Good.
Yeah, there was one system specifically that I was like, oh, they're really pressuring him to get him out of here right now.
We hear that a lot.
Yep.
Yeah.
Are you guys experiencing discharge issues from all these new hospice companies coming into town, doing a little bit of care, many of them owned by providers who allegedly, have taken it? But I'm hearing there's a lot of patient dumping in hospice. Are you guys?
So I actually, after this, we're going to talk about hospices and hospice fraud.
Say if that's our next slide, what a great transition.
I don't think it might be the next one.
I don't know, yeah,
but I want to kind of go over a couple more of these. So discharge or transfer patients with all necessary medical information to the appropriate post-acute services provider. We get a number of places who are allowing people to come into their hospital who are not licensed individuals, who are not licensed referral agencies, and allowing them to meet with patients to get them sent to their group home. but it's not licensed. They don't provide care. They're basically renting them a room. And I'll be honest, I've been in a billion of these, and they are slums. They are holes. Yes?
Sorry, I have to correct that. It's not group homes. It's called
Unlicensed.
Go ahead.
independent living.
They call themselves independent living or sober homes or whatever they want to call them. If you look at the statute or the NAC's, the Nevada Administrative Code, they're group homes.
Yeah.
I've been in a number where I go in, the food is locked up. The medication is locked up. The house manager has zero qualifications to provide care, isn't CPR certified, hasn't been tested for TB or any of those things. We've been in one where the house manager was blind, but this was the person responsible for unlocking the medications and divvying them up to every resident of the home.
He wore the key around his neck.
He literally locked us in the house when we came to investigate,
Yep.
which we thought funny.
Then you got bed bugs.
So they will not call themselves group homes, just like you said. We call them group homes because we think that the licensing agency should be cracking down on them.
Yeah.
That's why we call them group homes. And I'm going to continue calling them group homes
Yeah.
because of that. I will not give them the satisfaction of calling them independent living facilities because I disagree with it. But licensed facilities need to understand they are responsible to send them to a licensed facility for care if they require care. You can't just let anyone into your hospital or your facility to advertise their place because you don't know how bad it is. And I'm going to skip to this one so that Andrew can talk about a really good example recently of why this can be problematic. Go ahead.
So I got to start a little history. So this is Lenny Alston. So Lenny used to be a CNA at UMC. Based on her position at UMC and obviously being a CNA there, she obviously was very much, I had patients at my disposal. So because of that, she managed to work it out that she was able to discharge patients to, so she had a licensed HERC home. So that's a 2-bed facility in the neighborhood where she had her personal residence with her husband. But again, the nature of the greed of some of these people, I'm not just going to be happy with a 2-person licensed facility. I could get 5 to 7 more people in my personal home, which isn't licensed, but they don't know, and I'll just take them home. So that's what she did. She had about 5 or 7 people in her personal home, a couple in the HERC home. The problem is she came home one day from work. It was a long night. One of the residents needed changing of his briefs, so she changed the briefs. She went outside to throw the diaper away in the garbage can outside. She left the door open. The individual, he had dementia, he was confused. He walked outside. They had a pool in their backyard, which was ungated, unfenced. The individual decided to walk into the pool. He fell in the pool. Lenny can't swim. She started yelling. Her husband eventually came down. By the time they finally got the victim now out of the pool, he was already deceased. They tried to do CPR, but he was already deceased. Obviously, they wanted to call 911, which they did, because obviously they had a death on their hands. But knowing, obviously, they were already in violation of the law, having all these other people in the home, they quickly decided, we got to get them out of here. So they put them all in the van in the garage, took all the medications they had that was in this one box, dumped them behind the washing machine. The unfortunate part, they opened up the garage to leave right when North Las Vegas Police Department showed up. So like, oh crap. So they closed the garage, went back inside, started dealing with the police. About an hour later, the police started doing some searching and looking around. One of the cops went into the garage. He's like, why are all these old people sitting in a van out here? And this was July, no air conditioning, obviously. So all these older people were now dehydrated. They all had to be sent to the hospital. So I charged her with involuntary manslaughter, neglect resulting in death. I charged her husband as well, because obviously he was at home. He knew all those people were. They were both convicted, obviously excluded. Great. We got somebody out of the industry. Thought we'd hopefully never hear from her again. No. Got a call from North Las Vegas where she was doing the same thing in North Las Vegas. She had her own private home. And again, the problem is these were beautiful homes. These were not like the slums.
So we went out to this new facility, and this is years later. So this happened like 2012?
2010. Yeah.
2010?
There you go. Yeah.
2010. That's right, because I was brand new and I helped the rest of
Yes.
it. That's right. Yes, and so that's what I'm saying. I want to say 21 or 22, we got a call from North Las Vegas PD, hey, Lenny's back. We all knew her. Yeah. Her name was familiar. And so we got together with North Las Vegas, code enforcement, ADSC was there, HCQC came out, and we went to one of the homes. Interviewed all the rest. And I'll be honest, the house was gorgeous. Very nice house, beautiful facility. Everyone was happy, well fed, taken care of, but not a licensed facility. and there were probably, I don't know, 9 to 12 residents, and this is a big house, in this home, which was great. But a convicted, someone who has been convicted multiple times of elder neglect was housing these individuals. Well, some of them are on hospice, 100%, some of them weren't. But guess how they got there? They were all at hospitals or skilled nursing facilities throughout town. And someone at those facilities knew Lenny and was allowing her into their facility to essentially sell her house to the residents of that place before discharge. Come on in, we got to get these beds open. Come on in, tell them about your facility. And I want to be honest, most of them were very happy living with her, which is great. That's good. But think of what could have been.
Right.
Let's say Lenny gets lax and gets lazy in those homes and does the same thing. How is that going to look on that facility that allowed her in? And I guarantee, I 100% guarantee, the people in charge of those facilities had no idea that Lenny was in there doing this. And that it's personal connections. Lenny has friends and family who are healthcare providers throughout the city. And they're letting her in to help her out. And I'm sure they are good-natured and don't mean to do any harm, but they're putting these elderly individuals in a situation where they 100% can be harmed, right? I wouldn't send my kids to a daycare where I know the daycare people have previously been convicted of child abuse. Not sending my kids there. I love them. I want them to be safe and happy. Why would I send the elderly to a home like that, right? So if you're running a facility, if you work at a facility, be mindful of who's coming in there. There are licensed referral agencies. I don't know of any, but sometimes they come and talk to us. There are licensed referral agencies that have licenses to do this, to come in and find people places. Use them. Be mindful of who's coming in. Yes?
I know we're at time, but
Yeah, sorry.
can you just talk a little bit about what's happening with hospice?
Absolutely.
Yes, I was going to say, we don't want to forget.
Okay,
Absolutely,
so
absolutely.
We got word a couple years ago from California. Andrew went to a meeting with representatives from all the different MFCs throughout the Western region and the Office of the Inspector General. And the meeting was all about hospice fraud. So we're going to start with talking about California. In California, they have had a humongous problem with hospice fraud. Literally, where they would have one office building and there would be 200 hospices all using the same address. And I'm not talking about like they have an actual inpatient hospice. I'm talking about at-home hospice. So people are in their homes, they're sending the providers out to see them. Okay, became such a problem in California that they passed a law. Their governor signed a bill preventing additional hospices from enrolling as providers for a certain amount of time. And they extended it until, I think, this year. But that's how bad the problem was. Like, we don't talk to Governor Lombardo ever. We don't have that kind of pull to the point where we're like, hey, this fraud is happening, please sign a bill to prevent it. But that's how bad it was in California. And literally, so the bill went into effect on January 1st, I can't remember the year. Between the time where they realized it was going to come and the time that it went into effect,
2 weeks.
2 weeks, hundreds more submitted paperwork to enroll because they realized there's this hole in the system that we can take advantage of. And so they all enroll. So what happens, everything kind of starts in California and the West Coast. When something happens in California and they tamp down on it, where do they go? They move east.
Absolutely.
They move east, right? And so Andrew being super proactive, we went to the Healthcare Fraud Task Force meeting immediately after that, told the U.S. Attorney's Office there, told the OIG here this, and said, hey, be on the lookout for this. There's some different things you can do to pay attention to this. One of them being the live rate.
Yes.
I don't know if you guys are familiar with that, but with a hospice, the live rate is how many people on your rolls as a hospice are living past that 6-month period. And the OIG, what is it, 30% is what they say is acceptable?
So there's a difference. The OIG views 20% live rate to be acceptable. The CMS views 30%. So the feds are between 20 to 30% as being acceptable. And obviously when we talk live rate, just to make sure we're clear, it's obviously anybody that is on your rolls as a hospice longer than 6 months. Obviously understanding there can be miracles, things can happen, people can survive. That's why they give you that 20, 30%. The problem is, at least in California, there were hospices that literally had live rates of 96, 97%. Yeah. Those people should not be on hospice. So that's, again, some of the things that, at least from a data perspective, that we've already shared with Medicaid and with our feds. And I think just real quick from our issue with hospice fraud is, the majority of hospice fraud, again, what we see is on the Medicare side because it's more federal. It's more elderly based on that aspect. There are obviously sometimes where we have the Medis where they're Medicaid and Medicare, and obviously then Medicaid's picking up that 20%. So, and we do have, I think, 2 or 3 current hospice investigations. But it sounds like the majority of them are going more through the U.S. Attorney's Office and more through that federal arm just because they have more of the exposure, because they have all the Medicare. And that's something the OIG has not come to us yet to try and go through the state side, because I think the feds, it's one of their mandates, it's one of their big things, like we want to crack down on hospice fraud. So I think they're trying to keep a lot of that in-house. Obviously, how well they're doing with that is...
Now, we have had a couple of hospice cases in the past that we've successfully worked up, and I can share an example of that. But the scheme generally is this. They sell themselves not as hospice providers, but as PCAs or home health providers.
Correct.
Hey, we're going to come in and we're going to help you do all these activities of daily living. Maybe we'll even offer you a therapist, a chat, all these things. And people don't know what hospice is all the time. And they're like, okay, great. This sounds awesome. I'd love to get all those services. Sign me up. And then I come knock on their door and I'm like, they say you're dying.
Yeah.
And they're like, what? I'm dying?
That's happened. That has happened.
I had no idea. And they're surprised. What's that? Yes. And so she's exactly right. What she said was they make up diagnoses.
This guy.
And they do, okay? So we had a case, I think we finished it like 5 years ago, but we worked it for a while. A kid named Akari Randolph McCombs. He grew up in California. They moved out here when he was younger. We called him the bubble boy. I can't remember what it was called. He had some disease where he was super, his immune system was basically junk. Yeah. And any kind of germ could seriously put him in the hospital for a long time. So he lived essentially in a bubble. He had a suit he'd have to wear when he'd go outside. He generally stayed home all the time. But his mom was very, very concerned about him and very involved in his life and in his care. He was in pain. Hospice shows up, sells their services. As a hospice, though, I should say. They didn't lie to her and say, we are a hospice. We can offer him, all these pain meds, help him feel better. So they have a nurse come out. Nurse is supposed to assess him, go through his medical records, do all these things. She does. She comes out, very nice woman. She calls the doctor. You guys might know the doctor. His name is Dr. Manesh Amin. He still practices here in town. He is not allowed to be a Medicaid provider, though. He was on vacation, I believe, when she called. And she says, this is what I see in his records. And he says, okay, put on his paperwork that he has mast cell leukemia, and I'll sign it when I get back to town. He comes back to town. And what I'm talking about, the signature, is the certification of terminal illness. They all have to do this. Every hospice, to get on hospice, a physician has to sign a certification of terminal illness that essentially says, I've reviewed the medical records, his medical history, this patient's medical history, and have determined that they have a terminal diagnosis and have less than 6 months to live. And literally, it says that on the paperwork that he signs. He signs it. Akari goes on hospice. They start prescribing him pretty serious pain meds. He has some bad reactions to him. He gets sick. We get a complaint about this from the family. We start looking at it, and I'm like, man, does he have mast cell leukemia? Talking to the mom. She's like, I've never even heard of this. I don't know what this is. When they came out and told me that he was dying, I was surprised because he'd been fine. He didn't have any new illness. He just had this one he's had his whole life. And so it sucked for us because we literally went back as far as we could, like 20 years, requesting this kid's medical records, and there were a lot of them. And then poured through all of them, talked to the state's medical director.
The medical doctor. The state has an actual doctor.
Had him look over them for us as like an expert to see if Akari had ever, once in his life, been diagnosed with mast cell leukemia. And he hadn't been. Not at all. Talked to the hospice themselves. Nope, Manesh is our hospice director. He understands his responsibility. He's supposed to look through those medical records and determine himself whether this patient has this terminal illness. He didn't. Interviewed Manesh, and he said the same thing. I didn't look at it. I just signed the paperwork. Mm-hmm. So this kid went on hospice, I want to say for 2 or 3 months, got a bunch of pain meds that he should have never got, and had an adverse reaction. Now let's say he died from it. Right? That's all coming back onto the doctor because he lied about that certification of terminal illness. So we charged him with a bunch of stuff, Medicaid fraud, all these other things. Eventually, he agreed to take a neglect of duty charge, which is essentially he acted in a way that was willfully acted in a way that was reckless with regards to life and safety. And he did. And he's lucky that Akari didn't suffer more adverse reactions, or we would have tacked onto that, acting recklessly with substantial bodily harm. We could have gone neglect. We could have done a whole bunch of different things. But because of that, he is no longer allowed to be a Medicaid or Medicare provider. If you go on to the Office of the Inspector General's exclusion list, which everyone is required to check before they employ someone at their facility or their healthcare clinic, he's listed on there because of that neglect of duty charge. He got lazy, didn't do his job, falsely diagnosed this kid with this disease, and as a result, got convicted and no longer can accept Medicaid or Medicare. So he's only accepting private pay.
You can only do so much.
But that's how we see it, what's happening. They're giving false diagnoses generally. They're not selling themselves as hospice. They're selling themselves essentially as home health care. Yep. And so the people don't know. They think everything's great until I show up. Now, we have not seen a huge uptick in referrals. If they come, I will gladly take them. Yeah. There are two provider types that for some reason in my career I am overly passionate about, and that is hospice. Bad mental health providers and bad hospice providers. Bad hospice providers just piss me off.
And I have monthly calls with the U.S. Attorney's Office, and this I always ask, what do you guys do on a hospice? And I'm always asking for a Medicaid connection, because we know what's going on out there. And again, I don't know if they're trying to stranglehold and just handle all of these hospice cases, because they keep saying, oh, we haven't seen anything with any good Medicaid exposure yet. So like, okay. Well,
we can tell you this. There have been people that run legitimate hospices in town who are pushing the legislature to put a moratorium similar to what California did on hospice enrollment here. I don't know the appetite for that, but I know that there is people talking about that. Yes, good, but think about it. You have your whole life, you've gone to medical school thinking, I'm going to start my own hospice, and then you get out and you're like, I can't here in Nevada because
fraud.
There's a moratorium on that provider type. And so that's what I'm talking about. When fraud happens, it affects the good providers as much as it does everybody, the taxpayer. Absolutely. Yes?
Final question I have on the hospice is I've heard, and I certainly don't know, that there's a lot of paying for referrals. You guys, you know, a doctor gets paid $500 to refer, or a nurse gets paid $500. Are you guys experiencing that?
We get kickback complaints constantly.
Okay.
Refer them. If you think it's 100%. Happening, send it our way. I'll be honest, our kickback statute, our state statute is not the best. But the feds are very gung-ho about kickbacks.
And I think that's why a lot of those kickback scheme issues, especially with hospice, was really anything, because the feds have the Stark Law, and they make so many things about the Stark Law. It's a very easy law to make it work, and as Matt said, our state version is not as easy. So they're looking at those Stark Law issues all the time.
And I should say, we're not just sitting on our hands about that state law. We're working on getting that changed and fixed. But that really depends on politics. We don't have control over all of that. But if you have those complaints and we can't do it, we will send it to the FBI or the OIG so that they can take a look at it as well, 100%. All right, reporting. So these are our phone numbers, and not ours directly. We have an intake team, and that sounds awesome, but really it's two people, one person in the south and one person in the north.
We got an email address.
You can send us emails. You can call. This one goes to our southern office. That one goes to our office in Carson City. Send them. If you've got a question, send it. Or if you think something's shady, we're not expecting you to do the investigation. We don't need hard evidence. I mean, the better your complaint is, that more likely we'll open an investigation. But please send it our way. I will caveat this with there are 20 of us in the entire state. When I say 20, that includes our support staff, our investigators, our prosecutors. There's only 20 of us for what is easily the biggest state expenditure to police that system.
$16 billion.
And in addition to the fraud, we have to look at abuse and neglect as well, which is, it's difficult on our investigators to try to switch like that, go from one fraud investigation to an abuse and neglect investigation because they're so different. So we do what we can. If we get something and we don't have the capacity to work it, we make sure we refer it to someone who hopefully can. Yes?
Yes, I'm going to go back to elder abuse.
Yes, sure.
Chapter 200, one of the abuses is exploitation.
Absolutely.
So normally we would coordinate with ADSD, Legal Disability Services Division. We would call them, but the biggest problem that they have, as I've said, is exploitation because they are consent driven according to the law.
Yes.
Right? And with that, we are as providers, as care home, we don't call ourselves group home, we're licensed care home providers. Well, I don't have one anymore, but I represent them. That's where we have problems. We get blocked. It appears like we have no more recourse. If the elder protective services would say that, hey, sorry, we can't do anything about it because it's consent driven, and the person that you allege is being victimized is saying that, hey, you know what, it's okay that my son would take a lot of money from my bank account or would sell my house without prior knowledge, you know, then we have no way to deal with it. But it appears that with you guys, is there any way that we can coordinate with you when we know for a fact that an elderly is being abused, exploited?
So we don't have a consent rule.
That's not
we don't
required,
need
yeah.
their consent. I mean, obviously, if I walk in to interview that person, they're like, I don't want to talk to you at all.
That's not a
I
problem.
can't really do anything about that. I can't force them to tell me, right? I will say this, though. Generally, we don't handle exploitation. It's abuse and neglect, not so much financial abuse or neglect. There are caveats to that. What do we call it? The cantina account?
Canteen, yeah.
A canteen account where a Medicaid recipient gets a certain amount of money every month from Medicaid to help cover like cigarettes and toothpaste or whatever they need it for. If that's being financially exploited by the facility or someone at the facility, we can investigate that. But if it's their own personal money, we have to send all of those to the local law enforcement. They also don't have a consent, though, a thing for that. So you can send it to local law enforcement, absolutely. Law enforcement, like every other industry, has a hard time finding people right now, and they are extremely overworked. I know their abuse neglect detail has way more cases than they can possibly handle, at least for Metro. So they're going to focus on the bad ones first, and the less bad ones, especially. And I'll tell you this as well: if the victim doesn't want to press charges, they're not going to do it. They're just not going to do it.
And I do think from our perspective, I mean, yeah, Matt's right, we wouldn't need the consent. We could do an investigation, but I think we would like to have at least one other victim that is a little more cooperative, just because, especially if we're going to present something or progress something criminally, we're going to need that victim to testify in some sense. Like, we could try and build a case around them, and sometimes we can do that. And we do have these people that want to remain anonymous and not come out, and we try and build a case around them. But as we commonly say, at some point, if we can't do it without you testifying or being the linchpin to get this thing to go, that's where it's going to have to come down to. Now, we're going to file and subpoena and force an issue, but we're going to come back to that witness or our victim and say, look, if you got to have some help, if you want this to go, you're going to have to testify. And that's going to be on them.
If they don't want to testify, or they don't want to report it, or they don't want to cooperate with law enforcement, think of it like this. It's self-neglect, and self-neglect's not illegal.
Yeah.
Like, that's up to them.
Sorry.
So it sucks because you as the provider or as the facility want to do right by them and protect them. But if they're not willing to do anything about it, now that's different if they don't have the capacity to make their own choices. 100% different. Then refer it.
I think if they had playoff music, they'd be doing it. Right
Oh,
now,
you guys want us to leave. Got it. We got it. It's cool.
Ladies and gentlemen, thank you very much for your time. I went over it, but this is really good information. Thank you guys very much.
Thank you, David.